Welcome to Beyond the Mask. Today we welcome back a repeat guest and trusted voice in our community to dive into a topic that's rapidly gaining relevance in perioperative care: GLP-1 medications, new guidelines, and what they mean for anesthesia providers. With the rise in the use of GLP-1 receptor agonists for diabetes and weight loss, and you can see them all in our community here.
Yes,
everybody's looking thin and good. Anesthesia professionals are facing new challenges in preoperative assessment, intraoperative management, and postoperative care. How are professional guidelines evolving in response?
CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to Beyond the Mask, innovation and opportunities for CRNAs and advanced practice nurses, with certified financial planner Jeremy Stanley and CRNA Sharon Pierce. Jeremy Stanley has worked with CRNAs for more than 23 years, and Sharon Pierce is a former president of the AANA and the NCANA. Join us as we leave the operating room and learn the latest in the CRNA and advanced practice nurse industries. Beyond the Mask starts in 10, 9, 8, 7.
All right, and welcome back, Amy Reed.
Thank you so much for having me back.
It's so wonderful to have you back. So for our listeners who might not know you, maybe didn't listen to the first episode, I'll tell them to go back and do that now. But tell us a little bit about you and your practice and where you're located.
Sure. So I'm the assistant director at the York College of Pennsylvania WellSpan Health Nurse Anesthetist Program. We're located in York, Pennsylvania. And I currently practice at our primary clinical site, WellSpan Health York Hospital, as well as the surgical center, Apple Hill Surgical Center in York, Pennsylvania.
Okay, Apple Hill.
Yes.
All right, maybe I'll have to come pick some apples there. Was that?
We do have apple orchards
all right,
around.
good.
Yes,
Okay.
we do.
So that wasn't an inappropriate comment, as Sharon says I always say.
Hey, now wait. Weren't you the one who said your students listened to us and that you were going to have some street cred after being on the podcast?
And now a repeat guest. I mean,
I know, right?
I don't know what's going to happen.
Right.
Yeah.
Oh my goodness. I do remember. And you aired October 10th, 2024, Gut Feelings Exploring Aspiration Risks.
Yes.
Yeah. Now you remember.
I do. So let's talk about these GLP-1s. I mean, it's everywhere, as Sharon said.
Everywhere.
Why are they becoming so relevant right now?
Yes. Well, it's interesting because these medications are not new. In fact, the first FDA-approved drug was in April of 2005, so 20 years ago. But the reason they're so popular now is really social media, celebrity influence. TikTok and Instagram just amplified popularity. There was rumors of, Hollywood elites dropping rapid weight. And people came out and said, I'm using these medications for this purpose. And so I think social media has a lot to do with it, at least initially. The jazzy jingles don't hurt either. The marketing's pretty good, targeting both the consumer and the prescriber. So
yeah, and everybody's looking for the silver bullet.
Yes.
Right?
Yes.
This is pretty close to the silver bullet.
Yeah. Well, I mean, it has a lot of other health effects as well that I'm sure we'll talk about.
It is the silver bullet. So how is it affecting society at large and our healthcare system?
Yes. So, initially we think of, oh my gosh, we're going to have smaller BMIs in the operating room.
Well, I'm wishing for that.
Yes.
Not seeing that particularly yet.
But it's interesting because the clothing industry is actually struggling. Companies that built their brand on the American frame, they're struggling, especially shapewear companies.
Mm-hmm.
So like Spanx, we might not be seeing as much production in the future.
I didn't even think about that.
Yeah.
Yeah.
And then alcohol industry.
That's true.
That is true.
Because it does curb drinking.
It decreases dopamine signalings to that reward area in your brain.
Okay.
So you do get less cravings, less pleasure from it, and even less motivation to seek it out. And they're actually studying it for substance abuse addiction, both with alcohol and nicotine.
I was thinking that as you were saying that.
Yes.
Wow.
So
I don't know that I've really heard that much about nicotine and it curbing that.
it's early. They're looking at anything that has addictive qualities, even gambling.
I've
Really?
heard shopping.
Yep. So who knows what's in the pipeline?
That might be a good thing, for the finance people out there. My wife's shopping all the time. Well, let's give her a GLP. We're good to
That's
go.
right.
No more
Now
shopping.
Amazon's in
Credit card bills
trouble.
cut in half, right?
I know.
So what about the bariatric surgeons? I'm sure
Oh my
they're
gosh.
feeling the pinch on this, right?
Absolutely. There was an article that came out October of 2024 in JAMA, the Journal of the American Medical Association. And they said that between the year of 2022 and 2023, the prescriptions rose for GLP-1s 132.6%, but bariatric surgery rates dropped 25.6%.
Wow.
Over a quarter? That is significant for hospital systems.
That's huge.
Yeah.
There's all kinds of ramifications to that.
Yes.
Wow. Good and bad, I guess.
So from an anesthesia standpoint, what are the biggest concerns when a patient is taking a GLP like Ozempic, Wegovy before surgery?
Yes. So a year ago, it was pulmonary aspiration. It's still pulmonary aspiration, but the current literature is actually asking a really important question. Does residual gastric contents translate into pulmonary aspiration? And why this is so interesting is because the stomach contents of a GLP-1 is actually solid, which you don't aspirate the solid contents as easily as liquid. Now, certainly you can have aspiration with it, but they're looking at, patient positioning, your RSIs that are being done. CRNAs are just really good at their job. So in the literature, even though patients have an increase in gastric contents, they're not seeing the big increase in pulmonary aspiration that you would think you are seeing. So I think the awareness needs to be there, especially for upper endoscopy cases. That's where they're seeing the most aspiration risk. And I think CRNAs are being more cautious about how they're sedating these patients.
Well, they're unsecured airways. I do 30 endoscopies every Monday and Tuesday. By Wednesday, I'm comatose because I've already done 60 cases. And we're seeing a lot of retained contents, but I do follow the guidelines that we have at this particular point is hold it for a week.
Well, there's a lot of confusion around that, right? Should it be? I know my mom, we just went in and she's got to have a little procedure done and they've got her on it. And I think she's on Ozempic. And, I asked the doctor, I said, how long does she need to be off of this? He said, 5 to 7 days. It was kind of a very latent answer. Oh, by the way, 5 to 7 days. But he didn't seem real convicted in that. So it seems like there's a lot of gray in this as well, right?
His lack of conviction probably is due to new guidelines or new recommendations that have come out. So we're all really familiar with the June 2023 recommendations. If they're on it for 1 day, hold it, right? The oral dose. If they're on it for the weekly injection, hold it for a week. But in October of 2024, the ASA, along with the Multi-Society of Clinical Practice, so that involves bariatric surgery societies, the gastroenterology and the endoscopy surgeons, all different organizations got together. And they're actually saying that most people can continue taking the GLP-1 in the perioperative setting. They give some criteria, though, on when to delay the case or defer. And that's the escalation phase, which is usually the first anywhere from 4 to 8 weeks that the patient's on the medication. They're saying that's the most indicative of GI symptoms, increasing the risk for aspiration. So they're saying if it's in that first 8-week period, you really should defer elective surgery until they're out of that escalation phase. They're also saying that patients that are on high doses of these medications, that's also indicative of more GI issues. And they're saying if that's the case, that really you should encourage them to hold solids for 24 hours. So they should be on a liquid diet for 24 hours prior to any procedure if they're on a high-dose GLP-1 receptor agonist. And in addition to that, if they're currently having GI symptoms, they should be deferred for elective surgery until they're asymptomatic with the GI
Well, I think we're doing a good job with surgical procedures, but I do a lot of endoscopy. And that's where we're really having problems. And some of the GI docs will really push back saying, well, my association has said that it doesn't matter if they took it as long as they've been on clear liquids. But at the end of the day, my standard that I will be held to is not what the American Society of Gastroenterologists say.
You're right. Mm-hmm.
And it will be what the ASA guidelines are. So, that's still such a gray area. This is the first time I've heard anything discussed about if they're in their escalation phase. Nobody has talked about that.
Yep.
You heard it here on Beyond the Mask.
It is true because...
Well, it makes sense because that would be...
It's an increased risk for sure.
I have some CRNAs who say, well, the half-life of it is a week, so they need to hold it 2 weeks, right?
Interesting. Yes.
And then I have GI docs who have pushed back because they're like, why are you worried about solid food in the stomach? How many times do we get in and we find out that they've got solid food in their stomach because they have delayed gastric emptying from diabetes? Or I had one little gal, we go in, belly's full. I always like to ask, when did you have something to eat? She wasn't quite awake. Her husband said, well, we stopped and got something to eat on the way over because we've been in the ER all night because of her belly, and she was hungry.
And
she told nobody that she had eaten. So, you'll get a lot of pushback from these GI docs about all of this GLP stuff. It's getting better.
How is that explained to patients anyway? Because I think, if I'm in the room and I'm lying about eating and you come to me and you say, if you ate, you're going to die.
Right.
Hey, you know what? I'm going to be forthright at that point, right?
Oh, yeah. Well, that's exactly what we do. And they are asked multiple times because in the GI places I work at, we start at the front desk. Have you had anything to eat or drink? We start then.
Huh.
So the nurses are like, Sharon, we asked the questions. I go, I know you did. I've had patients, I'll get them back, and I've got the propofol plugged in. And I had one lady, clearly well-educated, high up in a local bank, and I'm getting ready to push the propofol. She said, it's bad if I ate a 6-pack of nabs walking through the parking lot on the way in. And for those of you not from the South, that's a 6-pack of little peanut butter crackers, and we call them nabs.
Nabs, yeah.
And so, yeah.
Yeah, the risk is there. We're really good at mitigating it, I believe. But the interesting thing about the new recommendations from the ASA from October is they're not what I'm seeing in practice.
Mm-hmm.
I don't feel like people are telling patients to continue the GLP-1 in the perioperative setting. And
not anywhere I work.
Right. And neither where I'm at either. And the ASA is actually saying that providers should really be cautious, the risk versus the benefit here, because there are so many benefits to the GLP-1s.
Right.
And the thing that I think is really interesting, they also call out the patients that are on for obesity and overweight or weight management. They're telling providers, do not ask them to hold it longer than you would ask somebody who's on type 2 on the medication for type 2 diabetes, because it introduced bias and discrimination. That's in the recommendations. But then if you cross the pond and you look at the European Society of Anesthesia and Intensive Care, their guidelines that just came out, an update came out in January of 2025, are completely different. They say, again, if you're on the oral formulary, hold it for a day. If you're on the medication for diabetes, the injection, hold it for a week. If they're on it for obesity or weight loss, they need to hold it for 2 weeks, which is 3 half-lives for the medication. And they're saying everybody on a GLP-1 receptor agonist should be on a clear liquid diet 24 hours prior to their procedure. So these recommendations are very different than what we're seeing with the ASA. So it's like, now we're looking at a crystal ball, like, okay, so now what do we do,
Well, I think the research will catch up eventually.
Yes.
But it's still too new.
Mm-hmm.
It's got to be changing the types of patients you guys are seeing in the OR. I mean, Sharon made, kind of a reference earlier that They're still somewhat large, a lot of patients, but are you starting to see any differences?
Not yet.
Anecdotally, no.
No. Okay.
Well,
not yet.
But I will tell you too, back to patients who are on these medications, usually they're heavy. And what problem do they have? They have the full abdomen, which pushes their stomach
pushes it up.
So it's got a shorter area to traverse to come up. So that's another thing. But I think once they catch on even more, and I think the reason why they haven't is because they're expensive. It's $1,200 a month or even more because we're basically backfilling and paying for Europeans. Europeans can pay $100, and the drug companies have got to make their money.
Profit somewhere.
And so Europeans not going to pay for it. Americans will.
Yeah.
Are you a resident or CRNA looking to transition into independent practice? The AANA and Beyond the Mask are here to help you thrive as your own boss. Introducing the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management tailored specifically for 1099 CRNAs. Lean into the feeling of freedom and embrace the opportunity to be your own boss with the AANA as your partner on this exciting journey toward independence. Enroll now and earn valuable continuing education credits as you chart a new course in your rewarding career. Visit aana.com/1099 to learn more and take the first step toward your new future. Remember, that's aana.com/1099 or click the link in the description of today's show. The 1099 CRNA Institute. Thrive as your own boss.
Insurance will cover it if it's for cardiovascular disease. We're seeing that there is an increase in covering the medications with insurance, but not to the extreme that, everybody that's on it for weight loss and even diabetes, unfortunately. It is recommended by the American Diabetes Association that if a patient's on insulin, it should be it should be a combination therapy. So insulin and a GLP-1 receptor agonist, or insulin with the dual GLP-1 GIP receptor agonist, which is the second generation of those medications. So we should be seeing more insurance covering it, but to be determined.
Well, even if you've got type 2 diabetes, like my husband does, he's overweight. He's on Ozempic. It cost him $1,200 a month out of pocket.
Okay.
Wow.
Very expensive.
Yeah, sure does. So we've had this discussion before, and we've had people who have done some research on this. For patients taking these medications, how can point-of-care ultrasound help us assess the aspiration risk?
Yeah, so point-of-care gastric ultrasound is gaining momentum, especially with the vast patient population that's taking these GLP-1 receptor agonists. I think before it was kind of like, well, gosh, I've been practicing for a really long time and I never use gastric ultrasound and I've had very minimal aspiration events. So why am I going to introduce this into practice? It's a tool. There's limitations to gastric ultrasound, but at the end of the day, it can give you an objective assessment preoperatively of what you're dealing with going back to the operating room. I think there's a fear of, am I going to cancel all the cases? But honestly, it can just guide your plan for your anesthetic, which is, I think, something important to highlight, because it's not that, okay, there's a full stomach, we got to cancel the case necessarily. That's going to be, what's your policy going to say about utilizing gastric ultrasound and how you're going to use it in your decision-making process for these patients.
Amy, do you have an example of that, like where maybe you've used it and changed your care plan because of that?
Yes. So I had a patient that it was endoscopy. And when I scanned them, they did have an increased fluid. I could see that their antrum had been expanded, but it was clear fluid. And the patient did say that they took water with their medication, but it was probably a little bit more substantial than what it should have been. Yeah, it was probably more like a bottle. And so in that case, because we saw the patient early enough, and of course in endoscopy suites, we're bringing them in pretty quickly, we just had them wait about 2 more patients, and then it was down to a normal level. So in there, we deferred the case. Now, if you have concerns about it, obviously you're just going to go to an RSI if you still need to get the procedure done, maybe not necessarily in an endoscopy suite, but in the OR. When I did my research for this and I was scanning patients, I did have somebody with a full stomach, and I reported that to the anesthesiologist and the CRNA, and they modified their plan because of that.
Well, we interviewed some kids who did a project with their DMP. And if you want to learn how to do it, you will gain proficiency with about 33 scans. So it's not something that is onerous, and you can buy the adapter to hook to your telephone or an iPad. So there are CRNAs who work in high-risk environments that want to know and want to do POCUS, and they buy the little apparatus. I would not be surprised, as we're taping here in Nashville at the annual Congress. We're in the exhibit hall. It's not fully set up yet, but I bet you that there's going to be a booth here where you can buy one of those little handy-dandy things if you want.
Yeah.
It's not hard. I mean, it really...
So y'all could even teach me to do it, right?
We could absolutely.
Yeah, okay.
You got to pull your shirt up.
Oh, okay.
So we can look.
There's even talks that, I've read some research. It's very difficult to implement in a department is what I'm finding. There was a study that was published, and it was a DMP project that they did a really good job of implementation. But for the person that's just really interested in wanting to use it, they're kind of just going in and making up their own indications of why they want to scan the patient. And I think it's an important tool. I think having our programs teach it from the ground up is going to be important. And even yesterday, I attended the AI workshop, which was awesome here in Nashville. And across the hall, they were doing a whole point of care ultrasound workshop. So people are learning. I think it's gaining momentum. It's another tool in your toolbox.
So looking ahead, what research or policy changes would you like to see to kind of better guide clinicians in this?
We definitely need randomized control studies. There's a lot of case studies out there, retrospective studies. I think we need to look more in depth about this, and the randomized control trials would help us do that. In addition, with the research aspect of it, we need to come to a consensus on how we're going to measure gastric contents. So in the numerous articles I've read, the methods of basically assessing the gastric contents is very different. So sometimes they use gastric ultrasound. Sometimes they use scintigraphy, which is the gold standard. Sometimes they're using the acetaminophen absorption test or the gastric emptying breathing test. So there's numerous ways to actually assess gastric contents. And I feel that if we're using all these different methods, can we really come to a consensus or a conclusion about the outcomes that we're finding? So I would like to see more a consistency on how we're actually measuring gastric contents for the research piece of it.
Sounds like a good job for the foundation. Maybe I should bring it to the foundation and let them do this.
Well, I don't know how many years it takes for Cochrane to weigh in, but eventually we'll have a Cochrane report on this. Maybe we need to talk to Drew Riddle about that, because Drew Riddle is over the Cochrane in the United States, and see if they're already looking. But you got to have a fair amount of studies to pull from for the Cochrane report. But one day.
One day. Well, Amy, as we kind of wrap up here, anything you want to get across to our listeners or leave us with?
Yeah, I would just say, if you're looking or you're interested in gastric ultrasound, there's a lot of workshops, obviously, but making it a department tool is something that does take a substantial amount of time. And anytime you're introducing something new or innovative or a different type of practice, you really need to have buy-in from a lot of people. Leadership, obviously your staff, docs and CRNAs, even people like biomed or IT or even billing, right? Can we bill for this? Can we make sure that our images get uploaded into the electronic medical record? And then if that's happening, then we can see what are the aspiration risks? What procedures maybe should have we scanned that patient preoperatively? What were the missed opportunities? And gather data that way. I think that's where we can get a lot of information if we're able to do that. But again, you got to have leadership buy-in. It's got to take a year. There's a great study by Jackson that was published in 2024 that talks about an implementation plan for point-of-care gastric ultrasound. It was a level 1 trauma center out in the Midwest. And I think it's the first publication I've seen that I'm like, hey, they did that right. Like that's not just a passion project. They implemented that into practice. So, you got to be thoughtful about it. A clear implementation plan and leadership buy-in is going to be important if you actually want to make this part of your department culture.
Well, Amy, excellent information. Thank you for all you're doing for the CRNA community. Thanks for being a repeat guest on the show.
Yeah,
We're
thanks for
so
having
glad
me. It's great
to see you here in Nashville. And Sharon, I'm going to say that's a wrap.
I think so. Maybe we'll see her in Boston next year.
Maybe so.
Thank you for tuning in to Beyond the Mask. If you enjoy the show and want to help us grow, the best way to support us is simple. Leave a review on your favorite podcast platform, share the show on social media, and tell your friends. Your word of mouth is what keeps us going strong. We're proud to consistently rank in the top 50 medical podcasts nationwide and to be #1 in the CRNA community. All thanks to listeners like you. Your support helps us stay there, and we couldn't do it without you. We'll see you on the next Beyond the Mask.